A 27-year-old woman comes to the physician with general malaise and dark urine for the past week. She reports she had a hard time making it to the physician's office because of pain and stiffness in the joints of her hands, wrists, and knees. Laboratory studies show sodium 140, potassium 3.8, bicarb 26, BUN 45, creatinine 2.2, hematocrit 30%, hemoglobin 10 grams per deciliter, MCV 79, leukocytes 3200, and platelets 120,000. Which of the following is most likely to be seen in this patient? Choice A, effacement of the foot process of podocytes. Choice B, diffuse inflammation in capillary wire looping. Choice C, deposition in mesengium causing splitting of basement membrane and tram track appearance. Choice D, glomerular basement membrane thickening with collections of large nodules. Or choice E, crescent-shaped deposition appearing on immunofluorescent microscopy. I'll wait 5 seconds and answer the question. So this patient has arthralgia, joint pain, and dark urine, which in this case seems to be hematuria. And part of the reason you can figure that out is because of what you can infer from the lab values. Now, I'm going to do something different this time I haven't done before, and I'm going to talk about the actual lab values and talk about the normal ranges as well. In the past, I haven't really done this because I assumed a lot of you will go through the trouble of memorizing a lot of your normal ranges because that will save you a lot of time on your exam. But I also understand that some of you are early on in your prep, so you might need me to help you walk through it as well. So sodium here is 140, normal range is 136 to 146, so this is normal. Potassium here is 3.8, normal range is 3.5 to 5, so this is normal. Bicarb is 26, normal range is 22 to 28, so this is normal. BUN here is 45, normal range is 7 to 18, so this is way high. Same thing with creatinine, normal range is 0.6 to 1.2. This is 2.2, which is really high. And with creatinine this high, you are likely looking at some kind of very severe renal failure. So that's the first thing we can infer here, that alongside the dark urine, even though I didn't give you the actual lab test for urine, you could probably infer that this is nephritic syndrome of some kind. And the rest of the values here are for blood cells, and they're pretty much all low, right? Hematocrit, 30%. Normal range is 36 to 46% in women. Hemoglobin is 10. Normal range is 12 to 16. You may have never noticed this, but a lot of times what you do is if you take hemoglobin and multiply it by 3, you'll get the hematocrit, assuming the hemoglobin is in the standard grams per deciliter measurement. So you have an anemia here, and the MCV is 79, which is also slightly low, normal range 80 to 100. So it seems like a microcytic anemia, and I'll come back to this in a second. First, notice that leukocytes are 3,200, which is low, normal range is 4 to 11,000. Platelets are low, 120,000. Normal range is at 150 to 400,000. So in short, you have a pancytopenia here. Red blood cells, white blood cells, and platelets are all low. This, alongside the arthralgia and nephritic syndrome, should be setting off alarm bells for you for SLE. Now, just to get this out of the way for those of you who are impatient, in lupus nephritis, the most common presentation is diffuse proliferative glomerulonephritis, where you have diffuse inflammation. And in lupus in particular, because of immune complex deposition in the capillaries of the glomeruli, you'll get what's called wire looping of the capillaries. So choice B, diffuse inflammation of and capillary wire looping, is the correct answer. So going back to the diagnosis here. Lupus, of course, autoimmune disease, immune complexes depositing in multiple organs. You often get a skin rash, malar rash / discoid rash. I didn't give that to you here because I thought that would have made the question too easy. You can get antiphospholipid syndrome, which causes a hypercoagulative state and recurrent miscarriages. You get endocarditis, you can get arthritis, nephritic syndrome as mentioned. And the autoantibodies in lupus can actually attack your hematologic cells, which is why you can get a pancytopenia. USMLE tends to really like thrombocytopenia out of these, but just know that it can happen to any of your hematologic cells. Now, as far as how questions on USMLE like to present it to you, they'll pretty much always give you arthralgia, joint pain, and they'll kind of give you a grab bag of various other symptoms that lupus tends to have. Obviously, if they want to be nice to you, they'll give you stuff like the malar rash, but just know that you do need to be able to identify lupus even if they don't give you that. So of course they would give you other stuff like lupus nephritis or some kind of cytopenia like I have here. And just to go back real quick to the microcytic anemia you have in this question, that's just me kind of adding an irrelevant detail, because sometimes when you have a hemolytic process happening, you might just happen to have a microcytic anemia. Or, this is a young woman, maybe she has iron deficiency anemia on top, or possibly anemia of chronic disease, you wouldn't know. Just know that microcytic anemia sometimes can just show up, and you don't always have to pull meaning from it in relation to actually being able to answer the question. Now, moving on again to the answer choice here, which is DPGN, diffuse proliferative glomerulonephritis. It can be caused by any number of things that will cause system-wide inflammation, which is what causes the histologic appearance, right? It's diffuse inflammation. Although capillary wire looping tends to be a little bit more buzzy for lupus specifically. But on USMLE, if they give you DPGN, it's usually going to be lupus. I think that's one big takeaway you want to have here. And we can kind of expand on that a bit by looking at some of the wrong choices here. So let's just move on to that, okay? Choice A, effacement of foot process of podocytes. This should be a pretty easy answer choice for you to eliminate, because you should be able to recognize that this is minimal change disease. It's a nephrotic syndrome. You wouldn't have dark urine usually. More common in children, often appears after an infection or a medication such as an NSAID. And it's called minimal change disease because histology is going to be normal under light microscopy. You need to use electron microscopy to be able to find abnormalities, which in this case is effacement of foot processes of the podocytes. Like I said, pretty basic diagnosis. You should have been able to eliminate this easily. Choice C, deposition in mesangium and causing splitting of basement membrane and tram track appearance. Now, it's not super important that you be able to understand specifically this description, but if you understand the underlying pathology, then it's actually not too hard to get the information you need. This is MPGN, membranoproliferative glomerulonephritis, which is another nephritic syndrome. And just look in the name, right? Membranoproliferative. So the membrane is proliferating, right? It's usually caused by immune complex deposition in the mesangium, which will split the basement membrane. So because the basement membrane gets split, on microscopy, you're going to see kind of two lines next to each other that form what they call the tram track appearance. And for USMLE in particular, this tends to come up more with hepatitis, especially hepatitis B and C, and C in particular because of cryoglobulinemia, right? It could also happen in various malignancies, but that's not as common. So summing that up very simply, MPGN, membranoproliferative, so membrane proliferating, immune complexes in the mesangium, split in the basement membrane, tends to happen with hepatitis C. Okay, moving on, choice D, glomerular basement membrane thickening with collection of large nodules. This is a very buzzy descriptor, and you actually need to be able to identify this on histology as well. This is diabetic neuropathy. So in diabetes, of course, you have hyperfiltration at the kidneys, which eventually leads to the basement membrane thickening and large nodules known as Kimmel-Still-Wilson nodules forming. And this happens because of non-enzymatic glycosylation of proteins eventually leads the cells to overproduce collagen in response, and that forms these nodules. If they give you a histology slide of what's clearly a glomerulus, and there's all these, basically these pink, pearly kind of circles all over the place, that will likely be Kimmel-Still-Wilson nodules, and you should be thinking about diabetes. Like I said, it's one of the few histology slides they actually expect you to be able to identify. Choice E, crescent-shaped deposition appearing on immunofluorescent microscopy. This should be very obviously crescentic glomerulonephritis or rapidly progressive glomerulonephritis, RPGN. As one of the names implies, on microscopy you're going to see a crescent shape of deposition appearing, especially on immunofluorescent microscopy. And what you want to know about crescent formation is that it's not specific to any condition. Crescent formation on a glomerulus basically just indicates very severe damage. And that's something you kind of want to carry over to a lot of these processes, is that they're not necessarily specific to one disease only. It's more that they're indicative of some kind of underlying process happening. And in this case, crescent formation, it means that your kidneys are getting into a really bad state. So actually in some late stages of some other diseases, for example, very late stage diabetic nephropathy, you can technically see crescent formation sometimes, but that's not important for USMLE, right? On USMLE, what they want you to know for rapidly progressive glomerulonephritis are the following conditions: Goodpasture syndrome, granulomatosis with polyangiitis, eosinophilic granulomatosis with polyangiitis, and microscopic polyangiitis. So just running through those real quick: Goodpasture syndrome, type 2 hypersensitivity against the alpha-3 chains of type 4 collagen. You will usually see a combination of hemoptysis with nephritic syndrome. And if they're nice, sometimes they'll show you the immunofluorescent histology, which shows linear deposition. If you see a bunch of really thick lines around the glomeruli, basically it looks like a huge green web, you want to be suspecting Goodpasture syndrome, especially if you also get the clinical findings to correspond with that. Granulomatosis with polyangiitis, formerly known as Wegener's. You want to know that this is associated with C. ANCA, and you can get hemoptysis, hematuria, and some kind of weird symptom involving the head, like a sinusitis or otitis media or something. A trick that sometimes people like to do to memorize Wegener's, or granulomatosis with polyangiitis, the latter is the correct name nowadays. If you draw a stick figure, and then you draw a C that goes through the head, the lungs, and the kidneys, that sums up a lot of the high-yield information about granulomatosis with polyangiitis. C. ANCA, head, lungs, kidney. Eosinophilic granulomatosis with polyangiitis, formerly known as Churg-Strauss. There is similarly another trick you can use similar to granulomatosis with polyangiitis, except in the case of eosinophilic granulomatosis with polyangiitis, it is P. ANCA positive. So if you draw a stick figure and you have a P that goes through the lungs and the kidneys, that is summing up a lot of high-yield information with this condition. P. ANCA, lungs represent some kind of upper respiratory involvement like sinusitis or rhinitis or even asthma. And of course, the kidneys still represent hematuria. And as the name implies, and you might have figured out, this condition also presents with eosinophilia a lot of time. You might have elevated IgE. And then finally, microscopic polyangiitis. The way I like to remember this is that this is just the other one that has P. ANCA, except it doesn't have the allergic symptoms of eosinophilic granulomatosis with polyangiitis. Doesn't have eosinophilia, doesn't have asthma, but it might still have hemoptysis and hematuria, as well as P. ANCA as mentioned. So bringing it back, this video is getting pretty long. Number one, you want to know how to diagnose lupus. You don't want to rely on just obvious things like Malar rash or autoantibody testing like anti-dsDNA or anti-Smith antibodies. Like those are very telling for lupus a lot of time, but they're not always going to give it to you like that. They're going to give you arthralgia and possibly some kind of cytopenia and maybe lupus nephritis without outright giving it to you. And the second thing you want to know is that lupus nephritis, most common manifestation is DPGN, diffuse proliferative glomerulonephritis, which is diffuse inflammation of the glomeruli and wire looping because of the thickening of the capillaries of the glomerulus. I hope you found this video helpful. I'll see you in the next one.